Pattison is an associate program director and clinical faculty at the Southern New Mexico Family Medicine Residency Program in Las Cruces, New Mexico. She received her MD from University of New Mexico and completed her family medicine residency at Southern New Mexico Family Medicine Residency. She completed a fellowship in global health and refugee care at the Family Health Center of Worcester and University of Massachusetts Medical Center. Following her fellowship, she resumed her role as faculty at Southern New Mexico Family Medicine Residency Program. Dr. Pattison's professional focus includes care of border communities, including those living in the area and traveling through. She also promotes an understanding of health advocacy to help family doctors utilize their skills to help the patients they care for. Her research efforts have centered on healthcare in the border region and resident education tailored to address the unique needs of this area. Dr. Natalia Galarza was born in Durango, Mexico, and grew up near Yuma, Arizona. Inspiring her interest in becoming a doctor was her mother, who is also a family physician in Mexico and has practiced family medicine for more than 25 years now. Dr. Galarza attended medical school at Universidad Autónoma de Baja California, located in Mexicali, Baja California. She graduated with honors. She completed her family medicine residency at Yuma Regional Medical Center, where she was part of the first graduating class. Dr. Galarza has worked on both sides of the international border as a physician, which gives her a firsthand understanding of this region's unique healthcare challenges. Her passions are global medicine, advocacy, and medical education. Dr. Galarza has presented at multiple national AAFP and STFM conferences since graduating from residency. Dr. Galarza started a mentorship program for underserved students in Yuma County 5 years ago. She believes in family medicine as a whole and loves the bond that this specialty allows physicians to have with their patients. She is currently a program director for a newly developing program in Yuma County for the Regional Center for Border Health that focuses on graduating family doctors who practice full spectrum and hopefully live and practice in rural areas after graduation. She is the current president of the Arizona Academy for Family Physicians and part of the trustee board for the STFM Foundation. So with that, Dr. Galarza, Dr. Pattison, please take it away.
Well, thank you so much for that introduction. So we're excited to go ahead and meet with everybody today. We're going to be talking about border health. Next slide, please. We have no disclosures. Next slide. Really, our objectives today is we want to go ahead and define border health in the context of family medicine education, talk a little bit about intersectionality in border health, global health, and public health, and review different types of clinical practices in border health and how to get learners involved. All right, next slide. So if people are willing to or interested in turning on their cameras and kind of letting us know, I'm kind of hoping we can make this a little bit more of a conversation and kind of tailor it to what your needs are. So I'd really be interested to hear from our participants kind of why you joined this topic today, what your interests are.
I'm a first-year medical student at Burrell, and I am part of our board for family medicine interest group on campus. So we just wanted to have someone from the group join in and kind of get a feel for what the topic was today, because it's kind of aligning with the mission of Burrell to serve the underserved, especially in like the Southwest and like the border region. So I just thought it'd be a good topic to join in on and then kind of sum it up and let the group know.
Awesome. All right, well, thanks for joining us. And Dr. Galarza, just so you know, Burrell is our local DO school. We have a lot of their medical students joining us in our program too. So, all right, and then there was something else in the chat, right?
There is something else in the chat from Joy Leatherman. Good to see you, Joy. She says, I live near the border. I was invited by a staff at NMPCTC, and she is a new residency coordinator.
Fantastic. Where are you at, if you don't mind putting that in the chat?
Silver City.
Nice.
Okay, awesome. All right.
Nice. Well, welcome everyone. I see that, yeah, everyone is involved with medical education one way or another, and that's exactly what Danielle and I do. So we obviously are very biased for this topic. we live in the border. This is, this is home for us. So it's very different from what other persons understand about border health and what border health is. Like all of you know, people do live here generations, like not just, fully arrived people, but generations of families live here and have made this their home uh, for multiple years. So I think that is a good set. Yes, it's a very mobile, dynamic environment, but it's also a very stable environment with defined expectations. And a lot of things are very unique to the whole border region from California to Texas. And then you will find very unique things in California, different from Arizona, different from New Mexico, different from Texas. That's actually one of the first things that we even notice among ourselves, Danielle and I, between our states when we started working. Since I'm in Arizona, I grew up in Arizona, Sonora border, and then Danielle in the New Mexico, Chihuahua border.
Yeah, absolutely. And I think one of the things that we kind of always have a little difficulty defining is what defines the border. We'll talk a little bit more about this in a moment, but I'm just going to use first names if that's okay, Natalia.
Yes.
Okay, so Natalia we know is directly on the border, right? And we're pretty darn close to the border, but we're within the checkpoints that we have in New Mexico. So about 100 kilometers north and south of the border is the defined area. If you go 100 kilometers north, you see all these checkpoints. Las Cruces is really surrounded by these checkpoints. And so we're kind of within that border region, but I think that's something to kind of think about when you're thinking about this topic and your interest in it, is sort of like, how are you defining border? Are you talking about states? Are you talking about directly on the border? Are you talking about regions? And we know if you look at the border region, if you look even from Texas to California, there's lots of differences, but if you compare both sides of the border in that area, if you compare it to either country, it's actually more similar within that border region, both north and south of the border, than it is if you compare it with the countries that they're part of. So I think those are kind of some interesting things to think about as we move on. But let's go ahead and go to the next slide if you're okay. Right. So why do we talk about this in family medicine, right? So we know we have the core competencies. We know part of what we do is taking care of communities and working with communities. So looking at the core competencies, if you're looking at systems-based practice, it easily fits into how do you understand local resources in level 3, understand the populations you're working with, and how do you participate in change and adapting practices for needs of that population. And then we know coming down the pipeline, we have the core outcomes. This year, we're going to be held responsible for the first 5, but not far away in the next few years, we're going to be held responsible for all 15. And if you look at the core outcome 15, your residents, when they graduate, should be able to effectively lead, manage, and participate in teams that provide care and improve outcomes for the diverse populations they serve. So if you're in these areas, this is gonna constitute that. Next slide.
And here we actually start with with the intersections. Go ahead.
No, you're good. Go ahead.
Okay. Sorry, with the intersections and global health. And those intersections that we find between global health and border health. So we do have from literature the definitions from global health. And one of the articles that you refer the most once you actually start working in global health is Copeland from 2009. And in this, they define global health as an area of study, research, and practice that places priority on improving health and achieving equity in health for all people worldwide. So it sounds amazing and, very aligned with what family doctors try to do and just doctors in general. The second one that we found that was very appealing is it's from the declaration, the Alma Mater Declaration from 1972. And they defined global health as a field of practice, research, and education focused on health and the social, economic, political, and cultural forces that shape it across the world. So very both definitions are very aligned with political and social determinants of health with an underlying there, and very, very broad, but they both obviously focus on achieving equity and improving health overall. Next slide, please. And then we also have the definitions of public health. And we found this again with an intersection where public health is defined as the science of protecting and improving the health of people and their communities. This is how the CDC Foundation defines public health. And another one is the art and science of preventing disease, prolonging life, and promoting health through the organized efforts of society. So very interested definition, but there's definitely something to do with global health. And then as you will realize next with what we like to call border health. Danielle, any comments, or do you want to go?
No, I think we can kind of loop back around after we talk a little bit about sort of like how Natalia and I really met up in 2019 and in kind of a global health concept. And we've always been working together to try and define what we see as border health, right? It's pretty vague, it's pretty amorphous, but I think the next slide really kind of shows us some of the things that we found when we were searching for definitions of border health. And I think, recently I was able to find this new one from the CDC. But let me talk a little bit about some of the earlier ones that we found first was, a range of shared public health issues that span the international border and necessitate binational collaboration to be effectively addressed, or a broad term characterized by healthcare markets, regulatory environments, health laws, environmental factors, healthcare, consumer and individual behaviors that shape the health of immigrants and other populations lying in the region intersected by the geopolitical boundaries of two or more nations. So both those like super complicated concepts, right? Lots of stuff in there, which is border health, right? You're thinking about all these different things that go into it, people that live in the area, people that travel through the area. At the time that we were starting to kind of form this collaboration was when we were really starting to see large numbers of people coming across seeking asylum. And I think when I recently looked for this, I found this CDC definition of border health, which is the area of public health that focuses on mobile populations and the communities they visit before, during, and after travel. And for me, that doesn't encompass what I think of it as border health. And so I'm going to let Natalia kind of comment a little bit more on that too, so she can give her perspective.
Yeah, we found this like very almost disregarding, as we were saying, for everyone, at least even for my part, right? Like my family has been living in this region, at least, like I'm fourth generation in this region. And then if you take into account that part of my family, like going back to my great grandparents, on the side of my great grandfather, they were Native American. His family has been living here, obviously, even more than that, right? Like hundreds and hundreds of years. So this is almost like I imagine an airport or just a port of entry, and that is the border. So which for us living here, we know it's not true. And that's why we were in the beginning making, emphasis on this is where people live. People live here. Great people live here. There's a whole economic structure here, a whole education. It's very unique. It's a lifestyle, definitely. So there is people living here. It's not transition. It's not just tourists.
Next slide. All right, so and then this is just a map of the US-Mexico border, which is obviously what we're talking about when you're talking to the two of us. And you can see that, you're encompassing, this is showing that area that's 100 kilometers north and south and what it's encompassing, all the different sister cities. There's lots of tribes in this area. There's lots of history and cross-border flow, right? So we know people have families on both sides of the border. Sometimes people are accessing care on one side of the border, or part of their care on one side of the border, part of their care on another side of the border. There's a lot there. But next slide. In addition, you can look at other borders around the area and see similar things. And I'm going to pass over to Natalia to kind of talk a little bit more about this.
Yeah. So, when we started really doing this research years ago, here in the States, you talk about border health, and the thing that comes to mind is the US-Mexico border. People almost forget that there's actually a Canadian-US border with its own challenges, obviously, and its own culture. But then we started being part of the global health community. We actually started realizing, like, can some of these principles that we have in the US-Mexico border apply to other borders around the world? And we did find that it is true, especially depending when you have a high resource environment, and then a low resource environment, how the economic flow, the people flow. Some of the conflict areas currently in the world have the same problems, right, with asylum seekers and refugees. So it is something that we can really extrapolate from here to some of the things happening and between Venezuela and Colombia, between Peru, Bolivia, and Ecuador, and then obviously in the East, Eastern Europe right now with the conflict with Ukraine. But I found articles even mentioning like the differences between the EU countries and not EU countries still in Europe, and why some countries wanted to join the EU because of that, to reduce that gap in resources or the benefits that the EU has. So it is very interesting to see that, and obviously some of the challenges that come from being so close then to the Middle East and Eastern Europe. And then Southeast Asia, you have also some conflicts, unfortunately, happening there, especially in Myanmar, Philippines, and then how it impacts the rest of the region and the flow that comes from it. And again, just the flow of people, economic, and the resource differences between all of these countries. Next slide. Danielle, you want to go from here?
Sure. So we're talking kind of a lot about this intersectionality, and I think, because we had met up a lot with when we were working on global health, we found that there's a lot of things that really correlate. When you're looking at border health, you can see international policy is going to be affecting the capacity of your work, right? Policies that are happening locally, nationally are going to affect you. Oftentimes you're working with agencies in more than one country. There can be some complexity in how both countries address a particular issue that you have to kind of navigate. I think we all agree that we really would like to achieve health equity. And so I think that's another area that is very similar. Resource differences, Natalia kind of touched on that. You really need a multidisciplinary approach. So how can you use your promotoras or your promotors to help you? How can you use other groups that you're working with? And then, you're caring for populations that are vulnerable. They may have documentation issues, or they may have limited resources. All of those things can kind of play in. Next slide. So we really feel like global health tries to reach beyond that rich-poor dichotomy and geographic borders, accepts human diversity and supports and promotes health as a human right. And I think we would like to see border health doing the same thing. Next slide. I'm going to pass off to you if you want to take the public health one.
Yes, and I think when we started researching this, obviously it was one thing, but for me personally, these intersections with public health didn't impact me as much as they did after 2020 or starting 2020, right? With the COVID pandemic, we really started seeing like, oh my God, it is all connected. We are all connected. So, many of the issues that we see are not unique to the border. We just mentioned that. And in fact, can be seen within the US system. Just like Kayla was mentioning, as doctors, we're focused on serving the underserved. There's underserved populations all over the country. You can go to Oakland, you can go to some of the inner city Detroit. You can stay here on the border. You can go to some of the regions in the Appalachian Trail. There's definitely a lot of underserved population. And you can extrapolate some of the experiences and learn lessons in border health and global health, public health into those populations. As border health and public health, they both think at a population level, like how is this impacting, right? Because you're dealing with a lot of flow, a lot of dynamic aspects of the population that you're serving. So how does everything policy-wise impacts my population, my patients? There is consideration of various communities in the region. And then the structural barriers to care. It's not just about having insurance and not having insurance. A lot of our patients they're American citizens, they work here in the US, but because of the cost of living, they prefer to live in the Mexican side of the border. So although yes, the ambulances can pick them up right there in the port of entry, there's still some physical barriers to medical care if it comes to that. Or patients that don't have insurance and they go across the border for their medications or their dental care. And also we have the goal, again, between the three: public health, global health, and border health. The goal is to achieve health equity. Next slide. Danielle?
Sure. So I think there are some things though that can be a little bit different about border health. One is you're working internationally, but you're really working binationally. I think it's very variable in global health, but oftentimes global health has a little bit more of a transient aspect to it. So there's a lot more potential when you're doing border health work that you're living in the area, right? So there's sort of that community aspect of, this is where we live and work and play and all of that stuff. There's the relationship with the healthcare counterparts really is a little bit more equal than you can see in other countries. So Mexico has a very strong healthcare system, right? Oftentimes it's dismissed, unfortunately, but it does have a very, very strong healthcare system. And so I think you're on a little bit more of an equal footing than sometimes when you're going to other places that maybe just don't have enough providers and things like that. And then there may be a little bit more opportunity for continuity of care since you're living in the area and nations that are mutually interested in working together. I think the two countries, the political, economic, and social systems are always involved, and you kind of have to keep them in mind. I think oftentimes, especially when you're looking nationally and you're looking at things that are happening in Washington, there's sort of a lack of awareness of border dynamics and what actually happens in the border region. Policies are passed with a misunderstanding of what it's really like. Political actions, domestic and international, can decide at a distance and have a disproportionate impact on the area. So a war in another area, you can see, wars in remote places, we still see people coming in from those areas. So we can see, recently we had large numbers of people coming from Haiti who had been living in South America for a long time, suddenly coming to the border region. And so something that happens pretty remotely can kind of have a big impact. And again, like we mentioned earlier, sometimes this can reflect similarities with other borders, but I also want to make sure Natalia has a chance to kind of talk on some of these talking points if she had anything she wanted to add too.
Yeah, no, it's true. I think people don't realize, like, just talking economics, here in Yuma, the city of Yuma is not very well, it's not small, but it's 150,000 people. We do have a winter visitor community, so that grows during the winter. The whole county is around 200,000, but it is determined that Mexican nationals coming across the border to shop, for leisure purposes, like during the weekends, their positive economic impact in the region is, last time they measured, that was 4 years ago, it was more than 50 million per year, probably more. They did see a negative impact during the COVID pandemic when the borders were closed. That obviously impacted possibly on the other side of the border, because now that people were spending their money there. So although not here in Yuma, in California, they closed the San Isidro port of entry for almost a day right before Thanksgiving in 2020, I think it was, or 2019. One of the conflicts with the past administration, and just less than a day that the San Isidro port of entry was closed, the economic loss for that region in San Isidro was more than 40 million, right? Because suddenly the interchange between it stopped. So it did have a direct impact in the pocket of a lot of persons. The other impact is also when we see in the agriculture industry, Yuma is called the winter salad bowl of the country. So if you're eating a salad in November, it's probably coming from here, from Yuma. 80% of the lettuce produced or harvest in the winter months comes from the region. So we do depend a lot of immigrant farm workers, either be, first generation migrants that come, establish here, live here, and then they start working on the fields, or temporary visas that these agriculture companies obtain for people from south of Mexico, especially Oaxaca and Guerrero communities. And they have to do that because over the past few years, when the visas were harder to get because of COVID, they were literally losing money because they were leaving produce on the fields that were not able to be harvested. So there is definitely a lot of impacts in the economy, political, that do translate and have a very direct impact, positive or negative, depending on the policy that people not living here, get. The other day I was and I don't want to get into it, but the other day I was even listening to some economic reports saying that Mexico has become one of the biggest exporters in by train, but also in chip containers. But then they realized that after some of the tariff conflict that happened with the past federal administration with China, China found a way of like, okay, I'm just going to export my products to Mexico, from Mexico, export them to the US and avoid some of those tariffs, or some of that conflict there. So, those policies are having direct impact, again, and how the traffic flows here in the border.
Next slide. So, obviously in the border region, we're dealing with multiple different groups of populations. And I think if you're thinking about how you want to incorporate border health, or if you should be incorporating border health, you want to think about some of these populations. So, obviously big in the news is asylum seekers, migrants, refugees. So we do get large populations of asylum seekers that suddenly need care. We've talked a lot about the longstanding communities and the fact that we need to be taking care of these groups, and that they can often be placed at odds with some of the new groups and can be overlooked. And then, we have the traditional cross-border flow. Families can be located binationally and when they're trying to seek care in other areas, or when they're crossing the border, they can be facing a lot of bias and misunderstanding in one or both communities when they're doing this. And then we talked a little bit about seasonal workers with seasonal insurance and things like that. Next slide.
And, just about the last slide, people don't understand how dynamic and how symbiotic the relationship is between the sister cities in the border. Like, for example, a few years ago, I have 3 young children, and my parents still live on the Mexican side of the border. So one Saturday morning, my mom is like, why don't you bring the kids? I'll take care of them. You and your husband can just have the day for yourselves. And I was like, yes, please. So we went, dropped them. My mom has her clinic, her medical office right across the border. So we literally just park our car on this side, walk with the kids to her office, drop them, say goodbye, and we'll see you tomorrow. And literally just came across walking. So it literally took us, like, by the time we parked, went across, came back, it took us less than half an hour. It was pretty easy, not counting the commute from here to the port of entry, but it was pretty straightforward. So the border, the immigration agent that my husband, they made us go separate, and then the immigration agent that was asking my husband some questions, and you can see who's new, you can see who didn't grow up in the border, you can see it. So you could see that this agent was new. He asked my husband, like, so how much time do you spend? What was your purpose of the visit? And it's like, oh, I came to visit family, just to drop my kids with the grandparents. It's like, oh, how much time do you spend there? Oh, less than half an hour. And it's like, really? You want to tell me that you spend half an hour, came all the way just to spend half an hour on the other side and then come back? It's like, well, yeah, my mother-in-law is taking care of the kids, so I just came to drop it. And then he was like, no, I don't believe you. And it's like, well, you're asking me, I'm answering. So he actually sent him to like secondary inspection. Which, you know, nothing happened at the end, but then you realize like how for him it was just not feasible that one of us went across the border to drop our kids with the family. Like it was somehow more impractical for him. But then I tried to put it into perspective. I'm like, if we live in LA and we live, you know, in Orange County and my family was in Redlands or San Bernardino, it would probably be the same amount of time, but it's because you have to cross the border that now is suddenly inconvenience. So people don't understand the dynamics, even people that work here. If you don't have that cultural humility, it is very, very evident. So, okay. And then obviously, you know, pertinent for us, we do have the clinical practices in border health. And by national examples, we obviously have primary care practice. Mexico does have type of a social medicine health system. So they are very focused on primary care. And it obviously includes OB care. And also there's some instances when we have families where they're pregnant and then the first trimester of their pregnancy, they do it in Mexico. And then they come across the border to do the last two or the last trimester of their pregnancy. Some of them are not Mexican citizens and some of them are not US citizens, but some of them are US citizens. It's just, you know, it's part of the dynamic, part of the custom. We do have occupational health clinics dedicated exclusively for agricultural workers. Like I was saying, is one of the biggest industries here in the region, and we're talking about millions and millions of dollars. So there has been some development in how to improve the health for those workers, because it's still very human dependent, the operation, right? So they want to ensure the health of these workers. We also have community health centers focusing on the minority populations, migration and immigration medicine, those immigration medical exams, or some of the ones that you do for asylum or refugee seekers. We obviously have hospitals and emergency medicines with the very different dynamics. Like we were saying, the refugee and asylum medicine, and then different projects binationally and just in the region for TB and HIV clinics, like the Amigo project and the Mexican side. And then we also have the TB project, the ECHO that the New Mexico University do. But there's a lot of communication, very rich, very established practice and communication. And there's always something always something new that the border region tries to help its own people and solve their own problems in a way. I think you're very good on this, I was going to say.
So there are some advantages definitely of working in the border region, right? There are some better outcomes working in the border region. And you get to work with dynamic populations. People can have extra ways of accessing cares. Although oftentimes there's a lot of bias and discrimination associated with those, with accessing that care, but that, you know, people can get cheaper medications, they can get access to dentistry, ophthalmology or optometry that may not be as available. Some patients have access to culturally sensitive providers and see themselves represented by their providers. So, you know, if they can go somewhere where they feel part of the community, that can be helpful. And there's a lot of opportunities for meaningful and lasting friendships among the healthcare providers. Next slide. So some of the opportunities is definitely with the cross-border coordination, breaking down some of these stereotypes and barriers. I think we can work some more on improving regional management of chronic and infectious disease, so that border can be kind of a barrier sometimes with that. educational development. I think what's been really fantastic is working with Natalia and, seeing how some of our struggles are the same, some of them are a little different, and how we're dealing with some of the struggles that we have. Getting to know our counterparts in Mexico, and working on breaking down silos and bubbles. Did you want to add anything to that?
No, I mean, obviously the opportunities with cross-border coordination, like you were saying, one of the things that we have noticed is that it is very region dependent, like here where I am right now, especially the organization where I am right now, it's very focused. Obviously it's in our name, but we are very focused. So I have found that they definitely have a better coordination across the border with our counterparts. And it is something not, it's something easy to do if you just put the time and effort on it. It's the same, right? Like people in the providers, doctors on the other side of the border, they really want to understand and how the system works and how they can improve care themselves. And there, like Danielle was saying, there is a strong health system there. There's I would even say that myself being a graduate from a state university there, you have a lot of influence from European schools. And some of the rotations that we actually do internationally are more towards are in Europe actually. So there's a lot of research being done and influencing the way it's done in the national centers or university centers. And that obviously influences some education centers in the border. But this stereotype that medicine is deficient or that is not, it's definitely not that.
Next slide. These are just some examples of some collaborations that I think we have found. So definitely border health rotations is one thing we have for one in Las Cruces that I'll talk a little bit more about in a second. Natalia, I know you were doing some binational grand rounds for a while.
Yeah, and we're going, now that I moved, we're creating our own program here. It's something that we want to do where we go with the medical school in Mexicali with their internal medicine residency program, their family medicine residency program, and we do biannual grand rounds with them. So our residents present clinical cases, their residents present clinical cases. And what is amazing is, again, the great level of medicine that is being done in some of these resource limited hospitals. And I always love to see how the residents from here react, like when they understand that it's like, oh, okay, they're really, really good, especially those that have never been in the border. Then they start, it's amazing to see, and it's great for the residents.
And next slide. So I'm just kind of curious if anybody feels like speaking up. Is there anybody who thinks they might be interested in creating a border experience or finding opportunities for the residents? All right, it doesn't sound like we have a lot of interest in that. So I'm going to skip over this slide and just talk a little bit about the difference between our two border experiences. And I'm going to go ahead and let Natalia go.
Okay, so yeah, I mean, like I was saying, it's in our name. The organization where I'm currently at is called Regional Center for Border Health. The main, the flagship campus is in San Luis, Arizona. So, You literally go on the back lot, on the back parking lot of our clinic, and you can see the border wall. So we are, one of the first things that I want to revamp now is the binational international ground rounds. I am starting a brand new residency program. I'm literally going through the ACGME application as right now. The cool thing is that it will be an unopposed program. So our residents that come here will be taking care of a very underserved population, but they don't have to compete with with the internal medicine resident, with the OB resident, with the endocrinology fellow, on how to treat this patient. So there's a lot of learning opportunities and very unique pathology here. And also right now we're very proud of our, the migrant asylum seeker process center that we have. Since it started in 2021, we have processed more than 200,000 people going through that center. So it's just amazing. My CEO has gotten a lot of praise because of it. And it also presents, again, learning opportunities, teaching opportunities, and another set of challenges when it comes to border health. And that's available. I've had students from U of A Tucson, U of A Phoenix, but also last year I had a student from the medical school in the Bronx. Oh man, it just, escaped my mind. But yeah, from a medical school in the Bronx in New York that came last August to rotate with us. So that is possible if we coordinate with enough time. And it was great. She actually was here at the same time with one of my other students from U of A. And together we actually submitted for a poster project for the Global Health Summit for the AFP. So there's a lot of opportunity like that you just don't come here and learn, which is a great experience, but there's also opportunities for projects that then, you can probably submit for conferences. And I think we will get accepted. It's a great project.
And then, so here in Las Cruces, we actually initially started our border health rotation as a response to a large number of asylum seekers that were coming into the area. And they were basically just being dropped off in the town, and the town kind of had to figure out how to deal with it. And we wanted to help try and meet the medical needs. And so initially it was mostly our residency program and our residents and faculty that were helping with this. But there were some other programs in the state that wanted to be involved too. And so, we'd always kind of been interested in potentially offering some experiences in this area. And so we looked into starting an actual rotation, which is now required for all of our residents as part of our social medicine curriculum. That was initially designed to help with these asylum seekers, but offered to other groups in the state. But we really did want to focus still on those people who are living in this area and underrepresented as well, right? And focus on the binational communities and all of that stuff. So it's a little bit of a different rotation in the sense that it's a very kind of spending a lot of time thinking about the bigger concepts of social determinants and social medicine and structural determinants of health. Residents, when they're on this rotation, learn about the history of the area. They learn about migration and ethics of volunteerism. So, you want to go help, but how do you do that in a sustainable way? We also want people to bring answers back to their communities, either bring education if they're not from the area, so people understand this area a little bit better, or, coming up with projects that can help the area. There's journaling. Those are the required ones, but there's some optional activities. Residents can learn about racism, bias, trafficking, trauma-informed care. There's a lot of journaling. It is a very coordination heavy how we've set up this rotation, because they spend a lot of time getting to meet with like Department of Health. They get to meet with asylum lawyers. There is a group in town that that does border health immersion, and they can join in some of their activities. They get to go to all of our residents work at the asylum shelter routinely anyway. But you know, they get to spend a little bit more time over there, learn a little bit more of the process and those kind of things. You know, it is a rotation that's open to other people if they're interested in it too. But I'm always happy to talk if people are interested in it or interested in learning about how we set it up. I'm always happy to share some of the information we gained. Next slide.
So in summary, you know, we do believe that border health fits really well with family medicine, and we are uniquely situated as a specialty to care for these populations. We need to, you know, understanding the aspects of global health, population health, and social and structural determinants of health will allow for a more robust experience in border health. Either you come, you know, to practice and stay here, you come for a rotation, or you just want to have a brief experience, that it is worth it. And experiences in border health may vary and should be adjusted to meet the needs of the community and the learner. Next slide, please. Or actually, can you go back? Oh, sorry. Danielle, I know that you have more to say about this.
No, I think you summed it up pretty well. I think, you know, we want to be outward facing. We want to make sure we're responding to the needs of our community. We want not to be coming in to save people. We want to find out what they need and see if we can help them and see how much we can learn in the process of doing that. But I think it's a really great way for people to learn about underserved populations in this specific area, how they can advocate for them, how they can help. And then, you know, I think if you are somebody who is working on a project or a program, I think this is one of those things that the more we can learn from each other, the better. It's been really great working with Natalia as far as really getting to learn some of the things that she faces, that sometimes they're similar, sometimes they're a little different.
Thank you. It's the same. One of the best things about this project, and like, you know, Danielle just said, we have met each other since 2019, is actually learning through the experiences, and then just being able to share and learn together. But it is a great community once you realize that you belong to the community. It's awesome. Next slide. Questions just in general about anything? You can put it on the chat if you don't want to ask directly. Okay. Okay. The references are there. We do want to be obviously very respectful of your time. Thank you so much for being here.
Thank you, Dr. Pattison and Dr. Galarza. I appreciate you so much for sharing on this topic. Yeah, so thank you again, everyone, for joining us. With that, it is 1:30. I think we will close if there are no more questions. And thank you again, Dr. Pattison and Dr. Galarza.
Thank you.
You too. Bye.